How do you manage acute appendicitis? Do we operate all the time? Or are antibiotics enough and we can manage it non-operatively? There are a ton of questions to consider. Do we give antibiotics after we do an appendectomy? How about an interval appendectomy? Do we need to do that? When do we need to do that? We're going to cover all these questions today at Citizen Surgeon. Let's do it. Welcome back to Citizen Surgeon. My name's Dr. Eric Pearson. I'm a pediatric surgeon and I'm here to get you to crush your exams and be comfortable on the ward, in the ICU, and of course, in the operating room. Today, managing acute appendicitis. So by now, you should be quite an expert when it comes to the appendix. You must have checked out that video on what is the appendix, why is it cool, what does it do? All right, if you haven't, check that out. And of course, the last video was on diagnosing acute appendicitis. All right, so how do you diagnose it? How do you do that history and physical exam? What labs? What imaging is important? Can we avoid CT scans? Yes, we can. All right, and today we're doing managing appendicitis, and that gets to the crux of the question, do we operate or not? So let's get into it. The references that I want you to consider today are number one, same one we talked about last time, the Bible of Surgery, my favorite textbook, and that's Sabison's. If you haven't picked this up, check it out in the link in the description below. Definitely check it out. It's worth it to buy this book. You'll have it forever, and you'll continue to reference it. I do from time to time. All right. The second is a collection of papers that I'm going to reference throughout the talk. I'm going to put the links to all those in the description below. So check those papers out, and that's going to help you understand why do we do an interval appendectomy if we need to, or what is the literature that supports non-operative treatment for appendicitis in adults and children. So let's start with that question. How do we manage acute appendicitis? When we think about managing acute appendicitis, a lot of times we want to think, let's get right to the operating room. But that is not where we're at. Often we're making this diagnosis in the emergency room. So for me, as a pediatric surgeon, I'll have a sick child next to their mother in the bed just like this, all right? And I have to start the management of acute appendicitis right here. And that's not with a knife. So what do? All right? Well, we start with IV fluid resuscitation, okay? Often these children will not have eaten for at least a day, okay? Maybe they've been vomiting. If they've had perforated appendicitis, they could have vomiting and loose stools. So they're going to be hypovolemic, probably tachycardic, and they have a SIRS response because of all that inflammation happening. So we got to start by resuscitating our patient, and that in a child will be 1, 2, even 3 20 mils per kilo boluses of normal saline. And in an adult, you may start with 1 liter or even 2 liters of IV fluid resuscitation to start to replenish those fluid losses. Now, of course, you do have to take comorbidities into account. So don't just blindly bolus patients. You have to take in that whole patient. But in general, I like to start with intravenous fluid resuscitation when I'm treating children or even adults with acute appendicitis. Well, what's next? Well, in the sepsis, the septic shock talk, what did we say when we identified a patient with SIRS or sepsis? Well, immediately starting antibiotics is incredibly important. So that's number 2 when it comes to managing appendicitis. So that's starting broad spectrum antibiotics. Now in children, if you have, and we're going to get to the difference between simple and complex appendicitis, but if you have a child with simple appendicitis, you can usually start with a second generation cephalosporin, something like IV cefoxitin. If you have more complicated appendicitis, so perhaps a large abscess, then we want to broaden the coverage, use something like piperacillin tazobactam, or also known as Zosyn. Okay, if they're penicillin allergic, you may want to use something like ciprofloxacin and flagellar metronidazole. Okay, so that's the beginning. So we want to IV fluid resuscitate, and then we want to start IV antibiotics, something like a second generation cephalosporin or piperacillin tazobactam, or in a penicillin allergic patient, think about ciprofloxacin with Flagyl. Okay, so we've done that. Now, to operate or not to operate. So let's first consider non-operative management of appendicitis. So we've done IV fluid resuscitation, we've started IV antibiotics, and now we've chosen to proceed with non-operative treatment. Well, what is the literature that backs that? Well, in adults, there is the CODA trial, there is the APAC trial, and I'll put references to those in the description below, but those have shown that non-operative management of appendicitis can be feasible and safe in adults, and in the majority of adults, non-operative treatment of appendicitis can lead to less days off work and a quicker return to those activities of daily living. In children, there is a mountain of evidence that non-operative treatment of appendicitis is a safe and effective choice, all right? Well, what are the success rates? If we look at the number of children that lasted a year without needing an appendectomy, we can see that about 67% of kids did not need an appendectomy at a year, and about 33% of children did. Now, when we take that out to 5 years, almost 50% of children ended up needing an appendectomy. So non-operative treatment is safe, but you need to proceed with some caution. And I certainly educate parents, but there is a chance that your child might develop recurrent appendicitis and need their appendix taken out. So when we look across adults and children, generally, what are the inclusion criteria for non-operative treatment of appendicitis? So in the 2 studies in children I just mentioned, the inclusion criteria were having imaging confirmed appendicitis with an appendiceal diameter less than 1.1 centimeters, okay, 11 millimeters. Now earlier we talked about how a diagnosis of appendicitis is having an appendiceal diameter greater or equal to 7 millimeters. So non-operative treatment inclusion criteria less than or equal to 1.1 centimeters. Second was having a white cell count between 5,000 and 18,000. And third was duration of symptoms less than or equal to 48 hours before initiation of antibiotics. Now, what are the exclusion criteria? So the exclusion criteria included having chronic intermittent abdominal pain, okay, having diffuse peritonitis on exam, having a positive pregnancy test, or having communication difficulties, okay? So they weren't happy with communicating with the patient, explaining what the risk factors were and what the outcomes could be, then they proceeded to surgery, as that is the gold standard for acute appendicitis, okay? In adults, we add in an age over 45 because in older adults, the risk of a cancer causing appendicitis is increased, so we want to take the appendix out because the risk of an underlying cancer is much higher than a younger population. When we look at this paper for non-operative management of acute appendicitis in children, we look at the 2 groups, so surgery and no surgery, and we see that in surgery, they get IV fluid resuscitation, antibiotics, and surgery within 12 hours, okay? And then the non-operative group, fluid resuscitation, antibiotics, and that was IV antibiotics for at least 24 hours, and then as soon as their appetite comes back and they're able to take food, we switch over to oral antibiotics. And then when they meet discharge criteria, so walking, pain is controlled, afebrile, tolerating a diet, they're able to be discharged on 7 days of oral antibiotics. And again, I'm going to put the link to the paper so you can check that out in the description below. Now, one thing is important is how did they determine failure in the non-operative appendicitis group? Well, failure was either clinical deterioration or no clinical improvement at 24 hours. They also included failure as patients that were discharged on the non-operative regimen and then returned to system, so returned back to the emergency room. And those children received a laparoscopic appendectomy. So again, how successful was this in children? About 67% success rate at 1 year, and then at 5 years out, about a 50% success rate, okay? So I think non-operative appendicitis is shown to be safe and effective, but I think we should still proceed with some caution. So this is a conversation I do have with families when we're choosing a management plan, and it's very patient specific. So if a patient doesn't have any excluding factors or contraindications for non-operative approach, it is a conversation that I will have. For adults, check out that APAC trial, the CODA trial, as these have been shown to demonstrate safety of a non-operative approach in selected adult patients. So let's talk about surgery. Perhaps I've met with that child or I've met with that adult and we've decided that we're going to operate for acute appendicitis. We're going to remove the appendix, okay? So what's my general approach? My general approach is if I have a patient that has less than or equal to 5 days of symptoms, and on imaging there's no evidence of a large phlegmon or a large abscess, then I will proceed with operative management of that appendix, and I will take out the appendix for myself using a laparoscopic approach. If I have a patient that has greater than 5 days of symptoms or has a large phlegmon or an abscess, then I'll consider an initial non-operative approach, perhaps with a CT-guided or an imaging-guided drain placement to drain that abscess, and then an interval appendectomy down the line at about 12 weeks. If we're operating, we have two choices. Number one is we can do an open appendectomy. So gridiron incision, right lower quadrant, right around McBurney's point, enter the abdomen, remove the appendix, okay? Or we can do a laparoscopic approach or a minimally invasive approach. So why minimally invasive surgery? Well, a lot of different studies have shown support for minimally invasive surgery. Here is a Cochrane database review, and minimally invasive surgery for acute appendicitis has been shown to have less pain, a quicker return to recovery, a shorter hospital stay, fewer surgical site infections, and fewer negative appendectomies. So all really important reasons to pursue minimally invasive surgery for acute appendicitis. Now, if we're going to pursue minimally invasive surgery, what are our choices? Well, there are a ton of choices. You can do a single incision laparoscopic appendectomy. You can do a 3-incision laparoscopic appendectomy. You can do a robotic appendectomy, okay? What I prefer is a 3 5mm incisions. I'll do that at the umbilicus, in the left lower quadrant, in the suprapubic area. And oftentimes I'll use the just right 5mm stapler, and that allows me to have very small incisions, and I found that this leads to less postoperative pain in my patients and quicker return to activity, quicker return back to competitive sports, which a lot of young people are interested in. For the electrocautery, I like to use just the hook electrocautery, and I take the appendiceal mesentery right off the appendix, and then I'll staple that at the base. Other ways to do that, you could use a 45mm stapler like an Ethicon, and that'll go through a 12mm port, or you can use vessel loops. So sometimes I will use Vicryl vessel loops, or you can use a PDS vessel loop, and that has been shown to be totally safe, very effective. You can also use Hem-lock clips. So you could use Hem-lock clips at the base of the appendix and divide the appendix, and you'd have a very nice closure. So it's very surgeon dependent, whether you do a single incision, 2 incision, 3 incision, you do it robotic, you do it 3 incisions with a particular type of stapler. It's kind of up to the surgeon. So remember, the best way to do any procedure is the way that you as the surgeon feel comfortable doing it, okay? And that is always the safest way to operate. So now you've done your laparoscopic appendectomy, and it's time to say, okay, do we have to give antibiotics or not? To answer that question, you have to decide, well, was this simple appendicitis or complicated appendicitis, all right? Now, we've changed kind of the verbiage of appendicitis to get towards simple versus complicated instead of non-perforated, gangrenous, purulent, suppurative, perforated. That's way too complicated. Make it simple. Appendicitis is either simple or complicated. So what's complicated appendicitis? Complicated appendicitis could mean you have a perforation. There's a visible hole in the appendix. You have a fecalith external floating outside the appendix. You have purulent material in 1 or 2 quadrants of the abdomen. You have a lot of pus or suppuration around the appendix. You see an abscess in the abdomen, or there's diffuse peritonitis. These are all complicated appendicitis. So what's simple appendicitis? Well, simple appendicitis is not complicated appendicitis. So simple is everything else. So if you have a dilated and inflamed appendix, but you don't have any of those things I talked about with complicated appendicitis, we call that simple appendicitis. And the reason to differentiate the two is if you have simple appendicitis, operation is enough. Their literature supports no further antibiotics. So I'll have hydrated the patient, I'll have given them preoperative antibiotics. If they need another dose within 60 minutes of the incision, I'll redose their antibiotics, do the operation, and if it's simple appendicitis, no more antibiotics. So for complicated appendicitis, the literature does support a range between 3 and 7 days. So some papers have supported that up to 3 days is the same as 5 to 7 with no increase in surgical site infections. So you just have to decide for your practice and in your system, what are you going to do and what are you comfortable with and what is well tolerated by your patients. One thing that's important to consider is, well, what is the non-operative approach in complicated appendicitis? Go back to that general rule. If I have a patient that has over 5 days of symptoms or a very large phlegmon or a large abscess, then I'm going to start with a non-operative approach. Now, I'm not saying a conservative approach, I'm saying a non-operative approach, okay? Because sometimes surgery is the most conservative thing you can do. But getting back to this point of the non-operative approach in complicated appendicitis, if I feel that surgery is too high of a risk, then I will initiate IV antibiotics and then watch the patient very carefully. If we have clinical improvement, then I'll continue that non-operative approach with an interval appendectomy approximately 12 weeks later. We're going to talk about that in a minute, all right? If we have clinical deterioration, then I either need to re-image the patient and look for an abscess, okay? Or I need to proceed with operation. So in that patient with greater than 5 days of symptoms or has a large phlegmon or an abscess, I will usually start that non-operatively, and the literature supports that, with an interval appendectomy 12 weeks down the line. Now that's in children, but a similar approach with initial non-operative management is also safe in adults. But the question now comes, well, do you do an interval appendectomy? Well, why do we do an interval appendectomy? Well, for 2 reasons. Number one is for recurrent appendicitis. Now, recurrent appendicitis is low as long as there is not an obstructing fecalith or a mass or a cancer that was causing that appendicitis. Okay, so do we need to do an interval appendectomy? I find that in young people that present with complicated appendicitis that have a fecalith or there's concern for a mass, I will plan for an interval appendectomy, all right? In adults, interval appendectomy has been shown to be safe. However, avoiding an interval appendectomy is also safe in patients that do not have a contraindication, so don't have a fecalith, don't have a possible mass, and are under the age of 45. Why that magical age 45? Well, in older patients over the age of 45, the risk of cancer causing appendicitis is significant. So in those patients, an interval appendectomy would indeed be indicated, just in case there's an underlying carcinoid or a mucinous adenocarcinoma or another type of adenocarcinoma present. So when we consider the timing of interval appendectomy, there is a range in the literature, okay? 6 weeks kind of at a minimum, up to approximately 12 weeks. I like to wait that full 12 weeks because the risk of recurrent appendicitis is extremely low, and that 3-month period gives plenty of time for all of the inflammation to go down. All right, I hope you enjoyed that talk today on managing acute appendicitis. Remember, we talked about first resuscitating IV antibiotics and then making a decision. Are we going to treat this non-operatively or operatively? Okay, so when do we consider non-operative treatment? So if we have that patient that has an appendix with a diameter between 7 millimeters and 11 millimeters, there's no abscess, phlegmon, or fecalith, the patient has had less than a couple of days of symptoms, and no history of chronic abdominal pain or those other contraindications, we could consider non-operative management. If we're going to do that, we want to make sure to educate them about what the failure rate is at 1 year and 5 years and how that child or that adult may need an appendectomy in the future. The other reason for non-operative approach would be in that complicated patient with greater than 5 days of symptoms or a phlegmon or an abscess. Manage them non-operatively initially and then interval appendectomy if indeed you choose that down the line. Lastly, operatively, you have so many choices. Minimally invasive surgery has been shown to be safe, effective, with less time, early return to work, less complications, less surgical site infections, less negative appendectomies. Minimally invasive surgery is certainly my option, but how you do it is up to you. 2 incision, 3 incision, 3 5mm ports, a single incision, a robot. You choose. Whatever the surgeon feels is the safest way to do it is the way you should do it. All right, if you enjoyed that, give it a like, give it a share, subscribe to the channel, give me some feedback, engage in the comments. That's how I know I'm providing value. As always, stay safe, study hard. I'll see you next time.